Hello students, my name is Moon and this is HE200, the EMT program at Queensborough Community College, lecture for Chapter 19, Altered Mental Status, which includes a little bit of neurology with strokes and seizures, but a big focus is on diabetic emergencies. The reticular activating system is the setup in your brain that coordinates activity levels and helps keep you awake and active or alert. So anything that affects the brain, normal brain function, would also affect the RAS, and the result would be altered mental status, which is the chapter for today. So what could affect brain function? Well, perfusion, things that interfere with blood pressure reaching the brain, because that's how you make sure that oxygen, glucose, enough fluid, other nutrients are reaching the brain. Trauma can affect that very thing, vital nutrients reaching the brain, or that some things like stroke and just the lack of the nutrient in the blood can be a problem too. So if blood pressure does reach the brain, but there isn't enough oxygen or glucose in that blood, then you will also get altered mental status. So let's say you're called to a sick. That's all you're told by the dispatcher, and then you arrive and then you see this. So what's the first thing you should do? Well, my first thought after BSI scene safety is make a general impression. So I have an apparent female, young adult lying supine. But then I can't help notice that she's looking right at me. Oh, can you see my mouse? I can't help but notice that she's looking right at me. So she seems to be kind of awake, but I don't know how awake. I don't know what her mental status is. But anyway, there's that. And then I'm looking around for any obvious life threats because, like I said in class, the assessment comes to a screeching halt if you see clear and obvious threats to life, like the limb is missing and blood is spurting out. Then you have to get on that tourniquet, pressure and tourniquet, and then once that's in place, then you can resume your assessment. But anyway, no obvious life threats. She does seem to be looking at me, so that's a good start, but that's not enough because AMS could mean that they are awake but not alert. Oxygen is absolutely a concern for EMS because that is a very serious, very common cause of AMS. So that's why we have, after the chief complaint is airway, breathing, and circulation. So we saw no immediate life threats. We go to the airway and breathing and then get the oxygen on. By this time, we have interacted with the patient, and the way the patient is, even though the patient is looking at us, the way they're acting is a little sus. It's making us concerned that there may be an altered mental status situation going on. So once we determine that's altered mental status, then the chief complaint is altered mental status. But how? Altered how? Well, then at least after the ABCs, you want to check for the questions of orientation. What's your name? Where are you? What time of the day it is? And what's going on? And if they're unable to answer all four appropriately, then that's a clincher. Any one of those missing is AMS. Unusual behavior, even if they're talking, even if they answer all four questions appropriately, any unusual behavior. And what's unusual? That's going to be from your own personal life experience. You know what you would expect a unaffected individual to behave like, and then you don't see that kind of behavior, then that could be possible AMS too. So this lady seems to be a little out of it. And then one picture now is not going to be enough. A video would have been better, but right away she doesn't seem with it. She doesn't seem all there. So possible AMS. And so the EMT is applying a therapeutic touch with one hand, but look at that. She's sneakily getting a pulse on the other with the other hand I've done that sometimes. Act like I am being supportive or something like that, but I'm actually sneaking in a little bit of a pulse check. So you have AMS, which is a level of consciousness issue, which makes it a load and go, and it also justifies calling for ALS paramedics. But then we make an EMS report to the dispatcher so that they can forward it on to the paramedics. And now you're ready for the secondary. And the secondary, then you then do the focused physical exam, you do vital signs, you do the history, OPQRST sample. Oh, by the way, if the patient is disoriented, not oriented fully, not oriented times 4, then you cannot really trust what they say in the OPQRST. And also, I think I've already shown to you guys that the physical exam, body systems exam, once the person is not unresponsive, you don't really have to do a detailed head to toe. Now, if their responses, if their mental status is really closer to the verbal response to the verbal level, then maybe you should do a detailed head to toe. But if they're able to hold a conversation, then you can do a focused physical exam. And what is a focused physical exam? Let's go back to our handouts. So let's go to, let's do this. Remember how to get to handouts. Let's go to laboratory, bright space for the class. And then let's go to content. And then we can go to assessment, handouts, assessment. And then we go to focused physical exam. And then I showed this to you in class already here. Whoop, here. So you saw already the body parts to check for a cardiac and respiratory emergency. And here is the AMS body parts to check. So the focused physical. You check around the head for possible trauma, like I said in the beginning slides. You check for signs of a stroke, which is the hemiplegia. You check for strange odor on the breath. What? Why do you care how their breath smells like? Maybe you don't want to be smelling random people's breaths. But I will show you in the later slide that this is very, very relevant. And like all the other options, all the other possibilities, you always check for a medical alert tag. So there they are. In the history, you should find out now possible past history of the possible causes of AMS, like anything that could cause AMS in the past, like past trauma, seizures. If they have a fever, because sepsis can cause AMS too. Medications, toxicities, drug toxicities can also cause AMS. So you include that on top of your basic sample questioning. Let's go back to the slideshow. And since the patient's answers may not be completely believable, you will often rely on friends and family. Family, of course, better, and they probably know where the medications are. They may even have like discharge notes from the last time they were in the hospital, or explanation pamphlets from the last time they were at the doctor, so they can share with you. But if no family is available, then you would have to ask for friends' opinions. But then the friends don't tend not to know that much about a patient's medical history. But you need to get that. Medical history is very much relevant in an altered mental status workup. Health alert tags and stuff, of course. Check their wrists, check their necks for medical jewelry. Children, if the younger they are, the less able they are to understand what's going on and understand the significance of the questions you're asking. But then children should be accompanied by an adult caregiver, so you rely on them for information. So what kinds of things will you be looking for? What kinds of things will you be asking for? And I already showed you in the focus here. You want to get this kind of information at the very least. By the way, this document, which was downloaded from a New York State EMS site a long time ago, this is the bare minimum. This is not a thorough and complete assessment of this kind of patient. It's just the bare minimum. It's like a foundation or a skeleton, and then as you get more experienced, as you become a veteran EMS provider, and then higher ranks in healthcare, you will start to fill this in with other stuff that you've learned along the way. So that's the big diabetes, the elephant in the room. Diabetes is the great imitator also, meaning that diabetes can not only cause its own typical set of symptoms, the syndrome, but its symptoms can often mask or mimic other diseases and cause distraction, what's the word for diversion, to confuse the healthcare provider, and then many times a patient shows up at the hospital or calls 911 and they're diagnosed with something completely different from what they really have, which is diabetes. So be on the lookout. So diabetes is a problem of managing sugar. The patient takes in a lot of sugar, and for sure here in Queens, New York, we eat a lot of sugar. All of us eat way too much sugar. But then what do we do with it? We're supposed to absorb it into our body, absorb it into our cells, and the cells turn that sugar into energy, and we use that energy to go about our lives. Any excess sugar that's left around is converted into fat, and that's why we get fat. The glucose molecule, however, is very, very large. So here's a nice little diagram I found. And the pancreas is the organ that makes insulin, and that flows with the sugar in the blood. But then the pancreas is the insulin is the hormone that kind of opens the gate. Insulin is the key. The cell is the wall, and there is a channel that is opened like a door that allows the large sugar molecule to get inside. Because sugar by itself is so large, it cannot pass through the cell membrane without assistance. So we're desperately dependent on insulin. We're desperately dependent on insulin working properly. What can cause problems with insulin then? Well, there could be a problem with the pancreas itself. So either congenital disease or other kind of medical problem or trauma, and the end result is that the pancreas is not making the insulin it's supposed to make. And then the person has to live with external sources of insulin, like injected insulin. And that's a type 1 diabetic. A type 1 diabetic is somebody who has the problem that the pancreas does not make its own insulin, or not enough. Maybe it does, but not enough. Why? That the whys are far above the level of this class. But anyway, this person is living now without enough insulin. I should make that clear. And so they have to inject synthetic insulin into their bodies. And then this is a very delicate, coordinated dance, because if they inject too much insulin, then too much glucose is taken out of the blood vessels, and the person gets into a different kind of problem in itself. If they don't inject enough insulin into their bodies, or they eat too much and the insulin they put in is not enough for it, then they have all of the problems of hyperglycemia. So the person has to act consciously, be very careful of how much they put into their body. If you don't think you're good at math, then you're going to have trouble dealing with this. The flip side is those who have to deal with this end up being good at math, because they have to do this to survive. They have to do this basic arithmetic to survive. Now, what about people whose pancreases are fine? They're okay. They're making insulin, and it should be enough, but the problem is the body is unable to use it. Unable to use it. Why not? Well, again, the whys is above the level of this course. At the paramedic level, they'll get into hints about why, but they don't really explain it to you until you enter the nursing program or the physician assistant program. But for now, the body just does not make best use of the insulin it is making. So the solution to people with type 2 diabetes is not to give them more insulin. The solution is to train their body to somehow be more sensitive to the insulin they do have. And then for the excess sugar that is floating around in their blood, they take other medication to sort of keep that under manageable control. Type 1 and type 2 diabetes is what they're called today. They're in the old days, it used to be called, type 1 used to be called juvenile diabetes, because they were found to be born without the ability to deal with this. And then type 2 was adult onset, because these folks tended to be seem to be born perfectly fine, and then later in life, like middle age, adult age, they suddenly start showing the symptoms of diabetes. So that's the idea. But then it turned out that diabetes itself is a genetic disease. So no matter type 1, type 2, the person is born with the genes that have problems with insulin utilization, production or utilization. And then it's the lifestyle that kind of brings it out. And then, because obesity is a rising problem, not only in this nation, but throughout the world, we're seeing children with type 2 diabetes and adults. Yeah, and so to call what a kid has adult onset, it doesn't kind of make sense. So instead, they switched to type 1, type 2, and now type 1, when you pick up your patient and you look at their face sheet, they tend to have something called non-insulin insulin dependent, meaning that's it, right? That's what they have, insulin dependent diabetes mellitus instead of type 1. And then logically, patients in type 2 are called non-insulin dependent because they don't need regular injections of insulin. They need to control their sugar intake. That's pretty much it. Both types have to control sugar intake. There's no way about it. There's no hack. There's no cheat. There's no way to eat as much sugar as you want and get away with it if you're a diabetic. That's it. By the way, the word mellitus means urine. Diabetes mellitus. Oh no, I think here. Let's go. Diabetes mellitus etymology. I showed you in class, right? Whenever I come on a term, I find it useful to search up the etymology, which is here the origin of the name, the history of the word, because it helps me understand what's going on. So, mellitus means sweet. Sorry about that. Mellitus means sweet. Diabetes, in context, means urine, go through, siphon. And so diabetes mellitus actually in ancient times means sweet urine, which implies that doctors 2,000 years ago used to taste their patients' urine. Don't worry, for those of you who want to become a doctor, they will never ask you to taste your patient's urine anymore. They have machines for that, which are way more sensitive and can even print amounts of sugar detected in the urine. But anyway, that's it. So what they found was that the sugar levels in the blood were so high that they were leaking through the kidneys into the urine, and then doctors were able to taste it. So what does this mean for the disease process? I mean, that was all very interesting pathophysiology, but what about what's going on with the patient in front of you? So diabetics have an emergency in one of two ways. One of them is hyperglycemia, means too much sugar in the blood. Emia means in the blood. Or hypoglycemia, which means too little sugar in the blood. But let's talk about hyperglycemia because that's what uncontrolled diabetes is all about. So the person eats too many carbohydrates, not just sugar, but carbohydrates. Because guess what carbohydrates have to do in order for the body to absorb it? They have to be digested into their individual sugar molecules. A carbohydrate like pasta, bread, rice, pizza, spaghetti. So all of these carbs, French fries, hamburger buns, all of these carbs have to be broken down into their individual components, which is actually, they're all just long chain sugar molecules, in order for the body to absorb it through the stomach lining and through the intestinal lining. You do not have pasta molecules floating around in your blood. You have sugar molecules, and you have to digest all of these long chain carbohydrates into sugar. So don't let somebody try to tell you, I control my sugar, I don't eat any sugar at all. Not a single drop, not a single gram of sugar in my body. And then you say, what else do you eat? And they say, oh, 5 pizzas, large, a day. Sir, you're eating too much. You're getting too much sugar in your body because your body has to convert that pizza into sugar to use it, to absorb it. So there's too much sugar in the blood for a typical American here in Queens, New York. And but for most people, the only result of that is they get fat. They convert the excess sugar unused into fat, and that's the end of the story. But for diabetics, people who have trouble making insulin or using their insulin, the sugar does not go into the cells. They don't get converted into ATP energy or to fat cells. They just sort of sit there in the blood. Have you ever taken like a warm or hot cup of water fluid and poured in a little bit of sugar and stirred it until the sugar dissolved? And then you tried adding a little more sugar and you see it dissolve. And then you added more sugar and you see it dissolve. And you just kept adding it. And then if you like used a clear glass, not the opaque coffee mug like I have right here, but if you used a clear glass and it was clear water that you heated in the microwave and then you added sugar, as you add more sugar, you'll see that less and less of it, of the more sugar is dissolving, and more sugar is starting to precipitate out, sediment out into the bottom of the glass, no matter how vigorously you stirred it. What's happening is the water is getting super saturated with sugar. No more sugar can dissolve into that warm water, and especially as the water starts to cool, then more sugar starts precipitating out of solution and settling to the bottom of the glass. Now, diabetics, humans cannot get to that level of supersaturation because they would die. But before that, there would be this high concentration of sugar in the blood, making the blood kind of viscous, syrupy in relation to what it's normally supposed to be. And that's going to cause a problem, and that's a lot of what's going on in hyperglycemia. So why would somebody be hyperglycemic? Well, they eat too much, but then why would somebody eat too much? Oh, the usual reasons: stress, habits, society, culture, advertisements, all the usual reasons why people eat too much. But then when a diabetic eats too much, they have too much sugar in their body. They eat too many hot dogs and French fries and chips and sandwiches. They just don't stop. And They eat as much as they want because it's now affordable to eat as much as you want, especially of the junk foods, and they end up with too much sugar in their body. Hyperglycemia takes a long time. It's a very slow process, days or weeks. But then, as the person continues in this uncontrolled hyperglycemic state, they've completely fallen off the diet wagon. They don't have any self control over what they're eating. Then they start to feel this chronic thirst. They're never not thirsty. They're always constantly hungry, and they seem to be going to the bathroom a lot. And then, as they get into extreme levels of hyperglycemia, they even start to feel nausea. So let's go to the medical terms, since you're going to be medical professionals. So polyphagia is eating too much, and what not and they eat too much not only because of society and advertisement and culture and stress, but now on top of that there's the insulin issue, because without insulin the sugar is not getting into the cells, and then the cells complain. You're like, hey, you up there, you're the people in control. I'm not getting enough sugar in me. I need more sugar to convert to ATP so that I can generate the power that I need to stay alive. So whoever's in charge up there, I need more sugar. The body tries to respond back saying, we are eating as much sugar as we can. And the cells are like, I don't care what you're trying to do. I need results. I need sugar. I need glucose. I need dextrose. I need lactose. Whatever you got, get it, send it down here. So the body feels hungry, even though they just ate. They just had a whole pizza by themselves, and ironically, illogically, they now have a craving for ice cream. Now, when does it end? How does it stop? There's other way. They got to find another way. So they just keep eating. Polyphagia, eat too much. Now there is all this sugar in the blood, and then the kidneys get into the act, because the kidney's job is not only to get rid of water, excess water in the blood, in the body, but also to help get rid of salts. And it's not just table salt, sodium chloride, but anything that acts like a salt, particulate matter, that affects the osmosis. Remember the term osmosis? Kidneys run on osmosis. That's how they do their job. So particles, not just salt, but particles that are in solution affect osmosis. And since the sugar levels are too high, these sugar particles act like osmosis, stimulating the kidneys to try to get rid of it. And so now the remember, sugar is too large to pass through the cell membrane. So sugar should really not pass through the kidneys, but the kidneys keep acting like the blood is too salty, and the kidneys keep trying to pump out the water, hoping that it'll bring the salt along with it. Actually, it's the other way. The kidneys keep pumping out the salt, hoping that it'll bring water with it, osmosis. But a funny thing happens when sugar levels in the blood get way, way too high. It's that sugar starts to leak through. They're not supposed to get through, but sugar is so concentrated that they start to punch holes. They start to rip holes through the cell membranes, and then they start making it through, thereby making the urine sweet. You wanna do a fun trick with your diabetic friend in the summer. Next time you and your diabetic friend are in the woods or anywhere near the unprocessed ground, have them urinate onto the ground, and then come back like an hour or two later, and you'll see that where the urine drops have fallen, ants have gathered around to suck up that sweet urine, because the ants are attracted to the sugar. So that's kind of fun to do, I guess, if you're totally bored. Anyway, there's sugar in the urine, and the patient is just urinating constantly, frequently. But That's all to react to the sugar, but the kidneys now have been cranking out all this water, dumping all this water out of the body, and so the person ends up being dehydrated, ironically, and so they have polydipsia, which is drink too much. The, the sugar has such a powerful osmotic influence around the body that it ends up, hyperglycemia ends up dehydrating the patient. So they're constantly thirsty. But then people with uncontrolled diabetes, uncontrolled diets, what do they reach for? A glass of water or a glass of Monster energy drinks, which themselves, they have 100 grams of sugar in it. So they're kind of repeating the process, this vicious cycle. So polyuria, polydipsia, and these are the classic signs of hyperglycemia. Now, if the patient still doesn't get their act together, they still allow diabetes to ravage their bodies uncontrolled, they can get to extreme hyperglycemia, where, once again, it's not so high that it causes the blood to become syrupy, because nobody survives that, but it's getting closer to that. And so there's profound dehydration, like actual symptoms, visible signs of dehydration throughout the body. Excessive waste products are released into the system. The system is starting to break down, and waste products are accumulating and being dumped out of the cells. And then we have this thing called diabetic ketoacidosis. I'll usually call DKA, because those of us in the profession, in the industry, don't like to say too many syllables too often. So DKA is easier to pronounce. So what's going on is, remember, the cells are not getting the sugar because the insulin isn't there, is not working, so the sugar is not getting into the cells. So the cells are getting desperate. In the past, with controlled diabetes, in those rare times their diabetes was under control, the excess sugar was getting into the cells, and some of the cells some of those energies was being turned into fat for a future long-term storage. Well, now was the day. The cells are getting starved for glucose, because none of the glucose is a kind of sugar, is getting into the cell. And so the cells switch to the fat stores they have. And when you digest fat stores, it releases ketones. Ketones is an acid, and ketones have a bit of a fruity smell when it comes out on the breath, and that's why you should check your patient's breath if they are possible diabetic and they have signs of AMS. If you've heard the word keto before, it sounds like the keto diet. And yeah, it's kind of the keto diet, because the keto diet is the idea that a person intentionally, on purpose, has zero carbs, does not take great care to make sure they are not eating any carbohydrates at all. They are eating all the fat and protein they feel like, but they make sure they carefully watch ingredients to make sure they don't ingest any carbohydrates. And the idea is that now forcing the body to switch to digesting fat instead of glucose will help them lose weight and other stuff. My personal opinion is that it's a bad idea, because carbohydrates have a very important job, which is to provide short-term energy. The job of fat is to provide long-term energy, and protein is to provide building blocks to create our cell structure and muscle. And so for short-term energy, like enough to last the next couple of hours until the next meal, we should have a little bit of carbohydrates. And then also the idea now that if you only digest fats, then you release all these ketones, and it's an acid, and they potentially making their blood acidic, lowering the pH of their blood. Remember back A few weeks ago, I talked about what would happen if the blood became too acidic. What would you see in this patient? And what was the other molecule? What was the other weak acid that I've been talking about in the past few weeks that that is naturally occurring, that sometimes accumulates in the blood, and what does the body do about it? And the answer was carbon dioxide. Carbon dioxide is a naturally occurring waste product out of normal metabolism, respiration, where we convert glucose and oxygen into ATP and some carbon dioxide and some waste products and some water and some heat. So if we generate too much carbon dioxide, which is an acid, it turns our blood acidic, and the body has chemoreceptors which detect this acidic level, and it stimulates the body to do what? And the answer is breathe faster. With diabetic ketoacidosis, the blood is so acidic that not only does the body breathe faster because it was tricked into thinking it's too high in carbon dioxide, but it's also breathing deeper, trying to get rid of this acid and what it thinks is carbon dioxide. So it's breathing faster and deeper. Rapid and deep breathing is Kussmaul's breathing. This Kussmaul will show up in test questions from now on to the rest of your healthcare career. You better know this word, and you better know what it means. It means deep and rapid breathing, and it's a sign that the blood is turning acidic. And that's the and part is very important, because many times in other diseases the patient will be breathing rapid and shallow or slow and deep, thereby maintaining the same amount of not cardiac output but minute volume, the same amount of minute volume, right? Minute volume is the volume per breath and then the number of breaths per minute. So multiply the two, you get total volume per minute. But rapid and deep means you are this patient is really blowing out the volume, getting really working that acid out of their body. That's Kussmaul's breathing. And what's on that breath? The ketones. And what does ketone smell like? Well, so the medical textbooks say it's a fruity odor. Have you guys heard of acetone before? Acetone shows up in things like nail polish. And so I guess fruity is a matter of opinion, but if you really, really want to know what ketoacidotic breath is, go get yourself some acetone. And maybe if you know somebody with nail polish remover, I guess that's something you can check out. And that's going to be a little more accurate. Okay, what if this extreme diabetic emergency is still left untreated? Like this person is refusing to go to the hospital. They're going into altered mental status already, but either they live alone and they're suffering from self-neglect, social isolation, or they're just so stubborn, and then the people who live with them have learned to leave them alone, not force them to do anything. And so they're all AMS, but they keep on continuing into this. And remember, this hyperglycemia takes hours to days. It's a very long, slow process. Untreated AMS in any cause AMS, untreated, unintervened, eventually leads to coma and then death. It's going to take several hours to days. So that is hyperglycemia. Let's talk now about hypoglycemia, which means this is too low blood sugar. So if the person has a problem with insulin, then how could they ever get too low blood sugar? Well, because insulin is only there to move sugar into the body, into the cells. What if they're not getting enough sugar? What if they're starving to death? that could cause hypoglycemia, or which is a little hard to imagine here in Queens, New York. But yes, starvation still exists among the poorest of the poor, the homeless, the severely people with severe mental illnesses. They can starve themselves. So I guess that's a possibility, but a very more common possibility that you would be called to in 911 is that they take their insulin, too much diabetic medication. It's more accurate to say that. So they take their too much of their diabetic medication and then does not eat enough. So that's the thing. Because what does insulin do? It moves sugar from the blood vessels into the cell, which means it causes the blood sugar level to go down. What does other medications do in diabetes? Most of the other medications also cause blood sugar levels to go down. So in order to do that, they have to get more sugar into the blood vessels by eating more. Not too much, but they should at least eat enough. The key here is enough. Now, why would a diabetic not eat enough? Well, how about they did eat, but then they threw up? Because remember, one of the signs of diabetes, late stage diabetes, is nausea. So maybe they have nausea, or they have, for any other reason, they have nausea. They ate something bad. They're having some other kind of medical condition causing them to throw up. So they took their medication and then they threw up their food that they were supposed to eat. Or they forgot to eat. Maybe they were too busy to eat. Or they eat, but then they over-exercise. So somebody is going to go to the gym, and then they were so busy in the morning that they didn't eat a proper breakfast, and they grabbed a cracker on the way out thinking, that's going to be enough. And then they don't really understand any of this. They just know that they're a diabetic, and the doctor gave them these medications and said, you're supposed to take one every morning. And so they say, okay, doc says I have to take it in the morning, so I'll take it before I go to the gym. And that's a diabetic medication whose job it is to bring sugar levels down. But then they don't eat enough, and then they go to the gym, and then they have a hypoglycemic emergency. So what are the signs of hypoglycemia versus hyperglycemia? The big difference, the most concerning difference, is very rapid onset. If hyperglycemia was hours to days, hypoglycemia is minutes to hours. And so that is the real emergency, because they could be like kind of okay now, but then they'll be very not okay in a short amount of time, which is the time spans that EMS works in. And so this person really, really needs to go to the hospital. Abnormal behavior, that's a kind of altered mental status, right? Mimicking a drunk. And that was a very common tragic story in the old days, where before police operations was aware of this kind of diabetes mimicking other diseases, they would catch somebody who was acting erratically, stumbling around, not answering questions appropriately because they were AMS. And then they would think, he's just a drunk. And they would throw him in jail because public drunkenness is a crime. And then they would think, hey, he's just a drunk. Let him sleep him off, and then he'll be more reasonable in the morning. But then in the morning, they find him dead. And it's happened so often, this and other causes of prisoners dying in jail overnight, that now anybody with any kind of possible medical signs or symptoms, the police have to call for EMS into the jail. And that's often, I did that often when I was on the ambulance. Respond to any of the the precincts in the local area to check on somebody who complains of things like altered mental status or chest pain or stroke symptoms, etc. Pale, sweaty skin, it seems to be found in both hyper-hypo. Tachycardia seems to be found in both hyper-hypo. Rapid breathing, it's not Kussmaul this time, but it's rapid shallow. So let's say rapid shallow versus rapid deep, which is Kussmaul. It's not acidosis they're fighting. And then eventually seizures. Why? Because diabetes, hypoglycemia, or diabetes in general mimics other diseases. What's causing this? Because brain cells do not have any backup energy storage. They are completely 100% dependent on the glucose in the blood. If there's not enough glucose in the blood, hypoglycemia, then the brain will start to starve and they will not generate the ATP they need to maintain normal function. And so without normal function of the brain, that's altered mental status. If left untreated, unintervened in hours, then it results in unconsciousness. Within hours, within minutes to hours, results in unconsciousness and can even result in permanent brain damage, and of course it could result in death. So this is where your lights and sirens really help to get there, to get to the scene. And then, since this is a level of consciousness issue, it's a lights and sirens, load and go, and in fact, really need paramedics. Really need paramedics, because what happens is, if they are too far gone, altered mental status, then there's no way you're allowed to put anything in the mouth to replace the missing sugar. But paramedics can get an IV and inject dextrose, which is another kind of sugar, directly into the veins, and that will literally save this person's life within minutes. Which is why a week ago, 2 weeks ago, I said that dextrose in a diabetic emergency is one of the 3 miracle drugs, and I'll leave it up to you to remember what the other 2 were. So what do we do when you have this patient who is apparently possibly a diabetic because of friends and family statement, and then or medical alert bracelet, or that you looked through their medication box and you saw things like metformin or insulin in there? So now you know, well, actually insulin is stored in the refrigerator, and then on assessment in the primary you find they are altered mental status. And then ABCs seem to be okay for now, but they're definitely have a level of consciousness issue. So therefore, identify AMS, call for ALS. Tell the dispatcher I need ALS for AMS. That's all they need to know. And then do the history, get as much information as you can, make sure they didn't hit their head, so focused physical exam, question friends and family, look in the refrigerator for insulin. The other medications, such as metformin, is going to be in their shoe box or the cookie tin or medication cabinet, wherever they have the medication. Glucose monitoring. So the glucometer is very useful here, not only for a possible diabetic, but any other medical patient, because remember, diabetes is a great imitator, mimics other disease processes. So even if it doesn't sound like a diabetic emergency, it's some other medical emergency, it's definitely worth it to go use the glucometer. And here there's the EMT is getting on some glucometry. Why does she have an oxygen mask on her if this is diabetes? Well, remember, this is EMS, and diabetes is one of the possible causes of altered mental status. But what about hypoxia? Maybe that's why. Maybe this glucose will come up perfectly normal, normal range, and it wasn't the cause of her altered mental status. Maybe there's something else. I'm just noticing that they're leaving the patient in her chair. I would rather, because if she's AMS, then at any moment she may fall off the chair. So I would feel much more comfortable if she could secure her to your stretcher or stair chair at least, because they got straps. So that way, if the patient loses posture, then they won't tumble out of the chair, hit their head on the floor as they fell. Anyway, what did I say? Oh yeah, normal glucose level. So what is the normal glucose level between 60 and 100? So this number, this is for textbook. Textbook, 60. Test questions, 60 is hypoglycemia. Now, if it gets any lower, then things will get worse. But 60 is the textbook cutoff for hypoglycemia. And then hyperglycemia is 140, according to your textbook. And then above 300, then any number above 140, it starts to get worse, and the symptoms start becoming more and more obvious. So over 300, sure, by that time you're over double the normal high level, so sure, it's going to be even more worse, and you start to get into like late stage hyperglycemia or stuff like that. Sometimes, and I think it's at 500, depending on the make and model of the glucometer, because different machines, different manufacturers have different settings. But at 500s, in the 500s and higher range, it won't even give a number. It just says high, and then now we got some real hyperglycemia action going on. Sometimes the number is so low that it just says low, and that means you are in a real diabetic emergency, hypoglycemic emergency there. So last week I offered to test any volunteers, their sugar level, but we didn't get time, and so unfortunately, but maybe the next time we meet I'll get this out, and then we can do that. Hopefully on the skills day you will also get a chance to practice on each other under supervision of a skills instructor. Now, for mild, which means the altered mental status is not really a danger at the moment, then you can possibly consider having them eat sugar or drink a sugary drink. Obviously not a diet drink, but something with a good amount of sugar in it, but not for serious or severe AMS, because then they may choke on it, which is the aspiration. Oops, wrong button. Aspiration. So what could you give them? Well, the patient may, if they're diabetic, they may carry around tablets, and you carry glucose, which is in a tube form. And so here is the lady sucking on a glucose tube. It's part of your tech bag. It's what you check in your 800 when you begin your shift. Just make sure the 6 rights are there. Make sure this tube is not expired. And again, you want to make sure that this person can handle it, because if they're too far AMS, then they're going to inhale that, and that's aspiration. They're going to choke. So it's about 15 grams of sugar in a tube, and that's not a lot, because what's in a typical container of your favorite drink now? So how about you pause this video, go to the kitchen refrigerator, go look go find your favorite drink and then turn it around to the back of the label and then read how many grams of sugar is in the container. Sometimes the nutrition labels say grams of sugar per serving, and then like 2.5 servings per container, in which case you'd have to multiply the grams of sugar by 2.5 to get the actual grams per container. And some labels actually come right out and say grams per container. I've noticed that recently. Maybe somebody passed a law recently forcing people to write down. So, hyperglycemia. What did I miss? Okay, so remember, hyperglycemia tends to happen slowly, like days, and hypoglycemia tends to happen rapidly in like an hour or 2 hours. And then you have some symptoms you see on the skin. I've had severely hypoglycemic patient with where the skin is slippery. It's not just slippery from sweat, it's like slippery from oil, kind of. It's like hard to grab the limb because it kept slipping out of my hands. Breath. So smell your patient's breath because they may have acetone breath, ketone breath. Fruity, apparently, as the textbook says. So now, what if nobody has a glucometer? The patient doesn't have one, or they lost theirs. You don't have one because you forgot to check for it at the beginning of your shift, which really puts egg on your face. You're going to have some explaining to do to the supervisor and even to your medical director if it becomes a real problem, like it really is a legit diabetic emergency, and then there are some very serious consequences. And then the question comes up, what was their sugar? And then if you say, we couldn't get it because I didn't have a glucometer, and the question is going to be, why not? So, and then you're in trouble. So, what if nobody has a glucometer? This patient does have a diabetic history, is now an AMS. You have a tube of sugar in your hand. Do you give them sugar or do you not? Because if it's hyperglycemia, then you don't give them the sugar. But if it's hypoglycemia, then you do give them the sugar. What do you do now? And there is an answer. There is a clear and accepted answer. And the hint is, remember which one happens rapidly, which one happens slowly, which one leads to death later, eventually, but not now, and which one leads to death now, soon. So that's all the information you need to make your decision. So that was the big one, and there are other causes of altered mental status, because what about sepsis? So remember, sepsis is a body-wide infection. We have all had infections of one small part of our body or another, and so what did it look like? It looked red. It was tender. It hurt. It felt hot to the touch, that body part. You may even had a fever from reacting to it. So that is localized infection. But when the same thing is happening throughout the entire body, that's sepsis. Either there is a body-wide infection, maybe there's infection of the blood and the blood goes everywhere, so now you have a body-wide infection. But an infection of the blood is septicemia, emia mean in the blood. And what's happening? So now, when that little body part that you had infected, like a thumb or your nose, got infected and got swollen and red, what's happening is the blood vessels in that area got wider and got leaky. And the idea here is that it's wider because, well, there's an invader, and so you got to call out the troops. But how do you get the troops there? Well, you have to make the roads bigger. So the roads got bigger, and the blood vessels got bigger, and so therefore they dilated. Also, the infection is hanging outside of the blood vessel, and your troops are there inside the blood vessel, kind of like on the highway. They got to get off the highway and get into the ground, get into the combat area, How do white blood cells do that? Because they're very, very big. Well, there are leaky gaps that appear in the blood vessels that allow the white blood cell to leak out of the blood vessel and then be able to reach the baddies so they can go chow down and do their job, which is eat the invader. So dilation and leaky. But that's for the local area, and that's all very fine and good. But now, what if this is happening throughout the body, all the blood vessels? Then if every blood vessel everywhere got bigger, what happens to the blood pressure? The blood pressure crashes. And so that is shock, because blood pressure is dropping, and the shock be caused by infection or perception of infection is distributed shock, also known, and this subset of distributed shock is called septic shock. On top of all of that, and the shock itself can cause altered mental status because now blood is not reaching the brain. But on top of all of that, there's another factor for AMS, which is the baddies, the infecting organism can itself release toxins that then travel up the venous stream to the brain and then interfere with brain function. So what do you look for with somebody who is in sepsis? Well, altered mental status, because that's why we're here, a drop in blood pressure, which then results in the compensatory heart rate, increased heart rate. So let me move that up. Drop in blood pressure, which results in compensatory heart rate and also results in compensatory respiratory rate, right? Because if not enough blood is reaching the core organs, then maybe if you made the blood travel faster, that would help. And if the amount of oxygen contained in one drop of blood is now insufficient, how about increasing the amount of oxygen in one drop of blood? So that can help. And then high glucose. Now, what's going on here? Is this like hyperglycemia? Some infections cause an increase in the blood glucose level. It's not because the patient ate more. It's that it's stimulating the body to release more glucose into the system. It kind of like fuel for the troops. You know, you can't just send your troops, right? You have to send ammunition. You have to send something for them to eat. So it's like supplies for your troops. Decreased capillary time is from the low blood glucose, blood pressure. Decreased cap refill time is the sign of low blood pressure. Right. So the brain is, so now that's another reason. Here's another reason for altered mental status. What did just happen? There's another reason for altered mental status. The brain can have a seizure. And what is a seizure? It is irregular electrical activity in the brain. Imagine that the brain is a delicate balancing act of signals going back and forth. And then if you can depict it, my favorite analogy is seeing a very nice, I spelled it wrong, but seeing a very nice image on the screen. It's a complicated image, a complicated balance of reds, greens, blues, brightness, texture, all that stuff. It's a very delicate exercise here. And then every neuron, every brain cell is acting, all a neuron can do is send a signal or not, ones and zeros, kind of like a computer. The analogy doesn't go very far, brains and computers, but for now it'll do. Each neuron can only transmit a 1 or a 0, but then you have billions and billions of neurons all working together to make some very, very complicated behavior. But now, the what if each neuron of the brain is not acting in synchronization, but it's kind of off doing random things, and then the picture you have is kind of like this, like static, and that's a seizure. Because of, let's say, this part of the brain is in charge of your left arm, this part of your brain is in charge of your right knee, and all of this different parts in charge of different parts of the body. Instead of transmitting a signal in synchronization, coordination, it's all over the place. It's just randomly firing off signals back and forth, and that's a seizure. What can cause a brain to not function properly in this way? Well, we already talked about oxygen, so give them an oxygen mask. We already talked about sugar, so the diabetes is the great imitator. It can even mimic seizure. We talked about toxins from various sources modifying brain function. There is other things that can cause a seizure, like a sudden spike in a fever can cause a febrile seizure. So lots of things, anything, and then trauma, of course, trauma can affect the normal synchronizing function of the brain. So lots of things can cause a seizure. You can have a partial seizure, which is just part of the body, or generalized, which is the entire body. Long ago, it used to be called grand mal. Grand meaning big, mal is bad, so the big bad. Now, mostly they say generalized. Tonic-clonic is the seizing, and then the gripping and relaxing, and it's just uncontrolled grip and relax of every muscle. But if the muscles are not doing it in a coordinated way, then it's a seizure activity. Body can get very rigid from that lack. And now, our strength is a function of our muscle power, but also our willpower, because the harder we flex the muscle or pull or push against something, the higher the closer we get to like a pain threshold. And then as the pain levels increase, our brain says, that's it, I've had enough, and then we stop trying, or we ease up on it. But if there's nobody up at headquarters to say that's enough, and the signal to the muscle is saying keep tightening, and I don't care what pain signals you're sending back, just I'm not here, I can't understand it, then the muscle can keep going until either it rips off of its attachment to the bone, or if enough muscles are in on it, they can even break a bone. There's no pain threshold. The muscle pushes through it. There's no person to consciously do this, and then it can cause some real severe injuries to the person. So that's why you allow the bones to move freely, and that's why you do not restrain the patient. Do not restrain a seizing patient, because it could cause them to rip their muscles or even break bones. There is a post-ictal phase, and post means after. So ictal is the seizure. So after the seizure, patients often have a period of AMS where they slowly come out of it. It's kind of like the brain is resetting, it's rebooting after that system crash. It's not a total shutdown reboot because the memories are still there. But anyway, that's kind of what's happening. And then before the seizure, there may be an aura. And people who have had frequent seizures in the past say that they can sometimes tell when a seizure is going to happen because there's be this aura. And this aura can be any of the five senses. By the way, five senses is a is a misunderstanding. We have way more senses than only five, but the five are the most famous. So they can smell something, hear something, see something, feel something, and it's for them it's associated with an oncoming seizure. What can cause a seizure? Well, what can cause a malfunctioning of the brain? So here are some of the causes, but there are other causes. Anything that can cause altered mental status can cause a seizure. Here are some more possibilities. A structural problem in the brain, because remember, the brain is a very careful, delicate interconnection of signals. So if there is like a structural problem that interferes with proper signal transmission, then you got a seizure. Sometimes they're born with it. Infection can cause it. Again, either the infection sends toxins up to the brain, or there's an infection in the brain. Metabolic problems, and there's way more diseases than just diabetes under the metabolic umbrella. We just learned about diabetes here in the EMS program. Idiopathic means they don't know. Not the doctor doesn't know, but medicine in general, the world of medicine has not yet figured it out. Other causes. Eclampsia is seen in pregnancy, and what happened is the blood pressure spikes so high that it squeezes on the brain so hard that it causes a seizure. So that's why we have a condition called preeclampsia, and in the labor and delivery chapter, the OBGYN chapter, which is like far into the future, well, now that I mention it, it's going to be November 24. I'll give it, okay? And there is a condition called preeclampsia, and these are all the signs and symptoms that warning you that eclampsia is about to happen. Eclampsia is the seizure. Preeclampsia is the spike in blood pressure leading up to the seizure, and the other symptoms that appear with that spike in blood pressure. That's eclampsia. Heat, excessive heat can cause a seizure, and so not only among little children they can have a febrile seizure, but also the sports aficionado who's pushing through the heat, or somebody forcing themselves to work through the heat on a hot summer day without proper hydration, without cooling strategies, and they just overheat their brain and the brain stops working properly. Anything that causes a brain to not work properly, drugs that cause brains to not work properly, can cause somebody to have a seizure. Here's some questions you should ask. So when was it? What was the person doing? Ask friend or family or coworker. What did the seizure look like? So what's happening is, most of the time, the vast majority of the time while working in EMS, you will not see a seizure in progress. You'll be called to a seizure, but then 7, 10, 15 minutes later, when you finally arrive, the seizure was long over. Instead, what you're seeing is the aftermath of the seizure, the post-ictal phase after the seizure. So you ask witnesses what was happening while the seizure was happening. How long did it last? These are all important questions. What did the person do after the seizure and before you showed up? If they had any previous seizure history. Did you see them hit the ground? Or were they already on the ground or on the bed when the seizure happened? Because if they saw somebody fall from standing to the ground, or nobody saw it happen, then you have to assume that there is some head spinal injury, so you have to take C-spine. Now, if you are unlucky enough to see a seizure happen because of random occurrence, or like you go to a patient who had a seizure and then in front of your eyes you watch them have another seizure, what you do is get them to the ground so they don't roll off the bed or something, not on your stretcher. Get them on the ground, because remember, you're not allowed to restrain the patient, and strapping them into your stretcher is restraining the patient. So you have to get him to the ground off your stretcher. Loosen restrictive clothing. Again, it's going to tighten or choke him. Get objects out of their reach that they may strike against or swing against. And again, as always, and along the same lines, protect them from injury by hitting something. Do not put anything in their mouth. First of all, they may bite your finger off if through a sudden spasm, and also it may shatter their teeth. And they're not going to swallow their tongue. The tongue doesn't fold that way. After the seizure is ended, then you can protect the airway, because they may vomit. They may the tongue may occlude the mouth, therefore blocking the airway. Consider an OPA, but the thing is that when people are post-ictal, they tend to start coming around, so they may start to become responsive to pain pretty soon. Consider C-spine. Roll them to the side in case they vomit, because they may very well do that. Get the oxygen on. Now, should you put oxygen on during the seizure? The thing is, during a seizure, no muscles are working in coordination, which means the diaphragm is not working, the chest muscles are not working, the person is not breathing. So if you try to force an oxygen mask on them, all you're really doing is putting oxygen in front of their mouth, and nothing is moving in or out of their mouth, because they're not breathing. Their muscles for breathing are not doing anything, they're just spasming. Should you get a BVM on while the seizure is in progress? The problem is that's restraining them. You have to hold the head down in order to get the BVM to work, or you have to do a jaw thrust, but that means holding the head down. So that's restraining the patient. So actually, no. You should, however, get the oxygen tank and O2 mask ready for when the seizure ends, because once the seizure is over, now getting an oxygen mask on is probably a good idea. So mask or cannula, why? So in New York State, you're not allowed to put a cannula on unless the patient refuses the mask. But if the patient is AMS, then they're not going to refuse the mask. So I'm not sure what your textbook is getting at with this. If the patient had injured themselves, like a cut or scrape or bruise or fracture, then be ready to splint and then transport. If the seizure that you are seeing in front of you continues for more than 10 minutes, this is a stat-ep. Stat-ep. You call dispatch force, ALS for stat-ep, because the thing is, like I said, during a seizure, they're not breathing. Also, during a seizure, every muscle in their body, especially grand mal, during a seizure, every muscle in their body is flexing, which means they're running through their ATP at a fast clip. They're draining the tank dry, and the muscles are contracting. They're converting a lot of sugar and remaining oxygen into ATP. They're generating a lot of heat. They're cooking themselves. They are cooking themselves. They are cooking their brain through their own body generated heat by all of that contracting muscle. So unless this seizure is broken soon, the patient will suffer brain damage from heat and also severe hypoxia. So it needs to be broken. And paramedics carry medications that will break the seizure, or has a good chance of breaking the seizure. Also, rapid transport, very important, because hospitals can break the seizure too. So instead, try to coordinate an intercept. The intercept means don't wait there for paramedics to arrive, but start moving the patient towards your ambulance, and then start driving towards the hospital. And then when at any point the medics can catch up to you, then the both of you pull over to the side of the road. The medics jump into your ambulance, and whichever EMT was in the back with the patient takes the medic's ambulance keys, go to their ambulance, and the two EMTs become drivers, driving the two ambulances to the same hospital, while the two paramedics are in the back with the patient taking care of them. That's medic intercept. So that was all about the full-on grand mal tonic-clonic seizures, but some patients can have a partial seizure, which is part of their body is doing it, not the whole body, and the rest of the patient and the patient themselves is alert to this going on. They're seeing it happen. It must be pretty scary. But with a partial seizure, then you just take him to the hospital. There won't be there won't be a postictal phase. You just get your information, do vitals, transport to the hospital. Be ready for a grand mal though. Be ready for a full-on seizure while you have them under your responsibility, because we don't know how these things happen, right? So as EMS, we cannot tell in advance if the patient will or won't have a seizure full-on in the next immediate future. So be ready for a full-on seizure later. What happens if they seize in your ambulance? You're kind of supposed to pull over and stop driving, because you're supposed to release the straps of the stretcher so you don't restrain them. But then you cannot transport a patient unrestrained in an ambulance, because what if you get into a car accident? So therefore you need to pull over and stop and call for paramedics for stat-ep. Absence seizure is this peculiar kind of experience where the patient is just behaving as they usually would, and then for like a second or two they just sort of pause and their eyes lose focus. They stop paying attention or something, and it's sort of like they got this 1,000-yard stare. It's like something suddenly occupied their mind, and it did. There is something there. It's a petit mal. They don't lose posture. They remain standing even. They definitely can remain sitting. It's just randomly throughout the interaction, they just sort of suddenly pause and do nothing for like a second, and that is a petit mal. They have to go to the hospital because the petit mal is a kind of seizure, and we in EMS don't understand seizures enough to know that they will not have a grand mal seizure later. And besides, petit mals are not a good thing, so this needs to be checked out. So that was seizures. Now let's talk about stroke, another problem in the brain. This is also part neurology lecture here. And so what's up with the stroke is there's two kinds of stroke. Either the artery to a brain, part of the brain is blocked by a clot, or the artery to a part of the brain ruptures because of an aneurysm. So remember my pictures about aneurysm, my slide about aneurysm 2 weeks ago with cardiology. Same thing here. Strokes are famous for being one-sided because a double-sided both hemispheres brain is kind of rare. I mean, a blood vessel breaking on both sides of the brain is much more rare. Instead, it's typically one vessel, one artery, which was on its way to one side of the brain. Remember how the brain is in two parts. Just in case you forgot. Remember how the brain is actually in two halves. So it's happening on one half and not the other half. And so they would have these various symptoms, which is better to explain in another slide. But here are some things that a person may have, and all of this is valid. But the thing is, confusion, dizziness, incontinence, vision problems, blood pressure issues. These are all non-specific. It can mean any number of 100 different problems, right? So it's not something that will definitively say, oh, therefore you have a stroke. That's not our job, by the way, to determine exactly what their problem is. But these are things, these are like other associated signs and symptoms here. Okay. And more associated signs and symptoms. Here. Okay. The depending on how large the blood vessel is will determine how much of symptoms you see. And communicating aphasia, which is not phagia. So earlier in this slideshow I said polyphagia, which is many eating, and with a G. But phasia with an S is a pronunciation or talking. So aphasia is not talking, not communicating. So we have the brain, and they need a blood supply, right? Because everything needs a blood supply. So brain artery, and you see how complicated these arteries are. It's a nice picture. Let's go with that. This is even a better picture. Well, let's go with this one. So, how big or how many symptoms a patient with a stroke will have is really dependent on which artery is involved. If it's a tiny little artery here, then only this part of the brain is involved. Can you see my mouse? If it's a tiny artery here, then only this part of the brain is involved, and you only get like 1 or 2 symptoms. But if it's like a major branch here where like this entire section of the brain is involved, then you'll see many more symptoms. So that's really it. And also, of course, different parts of the brain is in charge of different things. So depending on which part of the brain is involved, you'll have a different symptom too. Transient ischemic attack is when a clot suddenly appears and then the clot suddenly dissolves. So the symptoms appear for a moment, and then a little bit later the symptoms disappear. What's causing this? Well, one of the things going on is we're always making clots in our body. We're constantly making clots all over our body all the time. And that's kind of like a normal thing, but these clots are very tiny, and our blood has a mechanism for deleting, dissolving clots when they appear, and if the body determines they're not needed. That's a normal thing to happen. So it's possible that like an unusually large clot happened to appear in the brain for some random reason, and then the blood is like, what are you doing here? Let me check. Any reason why you need to exist? No? Okay, I'm calling cleanup on aisle 2, and the clot is dissolved, and then the symptoms disappear. This person still needs to go to the hospital, because even though this immediate danger is over, something caused that large clot to appear in the first place. The size of the clot is not normal. The doctors need to check it out. Like, why did they make such a large clot even though it dissolved this time? Because next time it may not dissolve and turn into a permanent clot. The cutoff for a transient ischemic attack is 24 hours. So never, ever, ever in EMS tell a patient they're having a TIA. Who the hell are you to diagnose somebody with a disease that you're not even in the window to determine it? Because when did this symptom happen? Like 3 hours ago? Then how are you going to try to tell this person that they are having a TIA? The reason why I'm getting on this is that I have heard of a story of a paramedic who tried to do exactly this. Oh wait, no, it was an EMT. Sorry, a paramedic is not that stupid. An EMT came to somebody with stroke symptoms and said, it's probably a TIA. You don't need to go to the hospital. And like this person is having a stroke symptom like right in front of their face, and they're trying to avoid transporting this patient to the hospital. I know this happened because the person, the relative for whom it happened, is a paramedic themselves. So that is just that's a head palm, face palm event in any definition of the term. Okay, so typical large scale strokes don't disappear on their own, and if they're not treated in time, they may be permanent. So how do you diagnose? Well, not diagnose, but how do you check for a large stroke? Because a small stroke, right? A small vessel stroke could be one random symptom that's completely undeterminate. And then for that, just anybody with a neurologic issue should go to the hospital anyway. But anyway, for a large vessel stroke, what you do is you check three things. You look for face droop, and this is the Cincinnati Stroke Scale. You look for face droop, ask them to smile. It's the face droop, like this gentleman here. So clearly something is going on. But now, which side is the affected side? Right? One side is absolutely clearly not symmetrical to the other, but which side is the affected side? So see if you can figure that out. Then the other thing is you ask them to hold up their arms and for 10 seconds close their eyes, extend their arms, and then try to keep them up for 10 seconds, and that's arm weakness here. So here this lady, the EMT holds their hands up, tell them to close their eyes and keep it closed, and then you let go and you do a count. You do the count from 10 to 1. I like 10 to 1 instead of 1 to 10 so that the patient knows when it's about to end. Otherwise, they may be worried that it's going to go on forever. So 10 down to 1 makes it clear that it's almost over. Anyway, see what happens, and then if one of the arms drops, and the reason why is because the patient doesn't realize it because they're not looking. If the patient is allowed to look, then it's going to invalidate the results. So that's arms. And I said there are three things, right? So then you look for slurred speech. Oop, wrong button again. You look for slurred speech. So you give them a phrase with a lot of S's in it. You can't teach an old dog new tricks. Well, that's not a very good phrase. It's from your textbook. But if you can think of other phrases where that has a lot of S sounds in it, that way if somebody slurring the speech, then you'll be able to hear it. So that's face arm speech, and if you put the letters together, you've got face arm speech, FAS, and then one more letter, T, is fast, FAST, and that's the Cincinnati Stroke Scale. T is for time, as in it's time now to go to the hospital, and also it's time, you got to find out when was the last time they were known to be okay. Oxygen is very important here, and I don't care now if their fingertip is showing more than 94%. It's about oxygen reaching the brain. So it doesn't matter if their fingertip is showing 99 or 100%. The part of the brain that's dying currently is going to need extra oxygen, if any is getting there at all. So give them that non-rebreather oxygen. So there's the oxygen, and then you know what, this belongs here. So Ask patient, friends, family, when was the last time they were without symptoms, aka last known well. So that's the other T. T, time, there. So last known well. Because when a large clot is the cause of the stroke, then there's still a chance to dissolve it with hospital medication, but not forever. At some point, the clot will harden and solidify, and then even hospital-provided medication will not dissolve the clot. It used to be a 3-hour window, and with the advances in medical technology and knowledge, they're able to like push it out a little further. Like it might be like 5 hours now, but you're really pushing it. And so, if you knew that the stroke happened 2 hours ago, then there's still time to undo this embolic stroke. Embolism is a clot traveling, so embolic stroke. Hemorrhagic stroke, where the aneurysm burst, well, that's just as soon as you can fix it. The sooner you can fix it, the sooner you can save brain function. And the earlier you fix it, the less of the damage is permanent. But now, giving a clot buster, something to dissolve clots, would be the worst thing you can do for a hemorrhagic stroke, right? When somebody is bleeding out of a burst vessel, you want them to clot. You want them to stop bleeding. But if it is a embolic stroke with a clot, you want to dissolve it. So now you giving one medication to the wrong kind will make it worse. So how do you know which kind it is? CT scan. The patient must go to a hospital that has a CAT scan, a CT scanner. Not all 911 receiving hospitals do. So you need to coordinate with a dispatcher or even medical control to know which kind of hospital this person needs to go to. If you go to a hospital without a CT scanner, you're wasting everybody's time, because it's going to take like several minutes to park and transport and bring the patient into the ER, and then wait for your turn to talk to a doctor, and the doctor's going to check out the patient and then give you this look like, what the hell are you doing here? There's nothing we can do for this patient. Either you take this patient right out and go to a stroke center, or I have to call for another unit to come pick up this patient, go to a stroke center. We are wasting time here. So you need to go to a stroke center, an ER that can handle a stroke and do the right thing. So find the last known well, tells you. Now, what if the last known well was like, it's now 7 o'clock in the morning, and the last time anybody saw this patient without these symptoms was 9 p.m. last night. So how many hours are we talking here? From 9 p.m. to 7 a.m. So you do the math, you go pull up a analog clock, you stare at the numbers until you can remember how to count, and then you will realize this is way outside that window to dissolve a clot. Is it even worth trying? And the answer, of course, is yes. Of course, it's still worth trying. Of course, you have to still go license sirens to the hospital. Don't even bother calling for ALS, because there's nothing that paramedics can do for stroke. The only thing the paramedics can do is yell at you, wondering why you're not transporting yet. Later in this semester, about ambulance operations. I think it's like the last lecture of this semester, or close to. Right. Another cause of altered mental status is dizziness and syncope. Dizziness, well, you know, that's the plain English definition, same as the medical definition. Feeling wobbly on your feet, like off balance, and can cause a little bit of nausea too. And syncope is the technical word for fainting. So now dizziness can be a vertigo, a sense that the world is spinning around you. Lightheadedness is the feeling that you're going to pass out. Syncope is the fainting, is what plain English would call fainting. It's a brief loss of consciousness because what's happening is something pulled the blood away from the brain. Something caused a temporary drop of blood pressure. It's typically a neurogenic shock, a very short-acting neurogenic shock. Neurogenic meaning that a mental state, a psychological state can cause a brief distributed drop of blood pressure. The blood vessels dilated all over the place, dropping blood pressure. Fluid pulls away from the brain when the patient is sitting up or standing, especially when they're standing. But what happens when they faint? They go horizontal. And once they go horizontal, the blood rushes back into the brain because gravity is no longer working against it, and the patient quickly wakes up. And that's really the key. There's no post-ictal phase of confusion. The patient just suddenly lost consciousness, and then as soon as they fell flat, as soon as they went horizontal, they suddenly regained consciousness, and they are able to think clearly once more. So what could cause sudden drops in blood pressure? An arrhythmia, either too slow or too fast heartbeat, can reduce cardiac output. The vasovagal response is the vagus nerve. The vagus nerve is the primary trunk of the parasympathetic nervous system. Remember what the parasympathetic nervous system is? So look that up, review it. And if it's overstimulated, then it can cause a sudden drop in blood pressure. Other things that can cause a sudden drop in blood pressure, hypovolemia, and that is when normally the normal minute, second by second up and down fluctuations in blood pressure is okay because in general our blood pressure is high enough. But what if through various causes the blood pressure is low and it's just on the margin, just on the edge, just on the border of almost too low, and then the minute by minute fluctuations in blood pressure causes it to drop up below the line and is now too low, and the fluid pressure no longer reaches the brain, and then the patient faints. Metabolic causes, chemical causes, toxins, diabetes, so metabolic diabetes, so there's diabetes is the great imitator, and inner ear problems also, like ear infections, otitis media, otitis externa, or maybe even otitis interna, because the inner ear has the balance, those semicircular canals of the inner ear is in charge of your sense of balance. So inner ear, semicircular canals. So all the way inside the inner ear, there are these three loops, and that's our three-dimensional sense. Each loop represents a dimension in the three-dimensional sense, and it tells us whether we are in balance or not. Toxins absolutely can cause somebody to faint. And other causes, there's 100 other causes to cause blood pressure to suddenly drop or the brain not work. And of course, there's the idiopathic. Idiopathic means nobody knows. Idiopathic doesn't mean one person doesn't know. Idiopathic means nobody knows, which means the knowledge of the world's knowledge of medicine is not yet advanced enough. Maybe we'll figure out some more reasons in the future. So what do you do for somebody who had dizziness or syncope? Your assessment. There's pretty much nothing to change in the patient assessment. The general impression life threats, level of consciousness, chief complaint, ABCs, EMS report, and then history, physical, focused physical, because by the time you got there, they have woken up already. If they hadn't woken up yet, then you have an unresponsive patient, right? So, but 7, 10, 15 minutes it takes for you to get there from the 911 call. By that time, with syncope, they've already awake. And then you ask the AMS questions. Remember, focused combined. Remember, focused combined for altered mental status. The AMS questions here. And so that's how you make sure you are properly covering all of the bases. And then, did you hurt yourself? What are we getting at here? Psychological, psychiatric emergencies. And that is covered in another chapter. Did anybody see this happen? That's very important, because there will be times when the patient doesn't remember what happened. So that's always a good to know. And if it's an ongoing thing, especially or possible seizure or diabetic emergencies, so it's because it's AMS, call for ALS. Tell them I need ALS for AMS, and that's all they really need to know. Check for trauma, signs of trauma, feel around the head to make sure they did not hurt themselves. And wonder now, is seizure or syncope a symptom of a larger problem? Maybe they have some kind of heart disease that causes blood pressure issues to come and go. So that's very real possibility. And that's another thing paramedics can do, is they show up and then they're going to put wires, electrodes across the patient's chest and get an EKG, because then the EKG will give a clue about if there's anything weird going on in the heart. I added this slide to your slideshow, and this is a mnemonic of all the known reasons to cause altered mental status. As an EMT, you don't need to know this. So if you're just trying to pass the course, then don't worry about this slide. But for those of you who are trying to maximize your knowledge of medicine, this mnemonic is something you will need at any higher level medical training, like paramedic and above, nursing, physician assistant, and of course medical school. All of them will learn this. So here is a sneak preview of the categories. Ooh, I misspelled that. Trauma. Okay, so there's been a lot of edits I've made to the slideshow, so I'm going to export as a PDF, and I'll upload this PDF, this revised PDF, to your Brightspace Lab Modified Lectures 1. And that's it for this lecture, so thank you for your patience, and you will see me in the next lecture.